Hey guys, how's it going? This is Dr. Kareem Godil. Welcome back to the channel. Today we're going to be talking about diabetes. The point of this lecture today is to go over the in-depth basics of diabetes. So I want to give a complete overview about the general aspects of diabetes. Today's lecture is aimed for anybody who's interested in diabetes. Let's say you were just diagnosed with it, or you have a family member, or if you're a medical student, you're thinking about medicine and you just want to get a better understanding before going into the nitty-gritty details. So what is diabetes? The definition of diabetes is three parts. One, you have hyperglycemia, which means you have too much sugar. Two, you have increased insulin resistance. And three, you don't have enough insulin being produced. So to really understand what diabetes is, you have to really understand what insulin is and what it does and how it works. The way that I'm going to explain that here is by using an analogy, where insulin is represented by a mailman. A mailman normally delivers packages to various houses, and the packages that doesn't deliver, it takes it back to a storage center. So the mailman that's being represented by insulin is taking these packages, which is sugars, and delivering to houses or your cells. And when it takes the extra packages and stores it as fat molecules. So what happens in diabetes is, one, there's hyperglycemia. That means there's a lot of packages in the blood. And insulin is going to be taking those packages to the cells, and the excess it deposits as fat cells in the storage center. The second thing is going to be insulin resistance. That means these houses that the mailman is trying to deliver the packages to are going to have beware of dog signs, no trespassing signs. The guy's going to be with a gun in his hand saying, hey, get off my property. The third thing is that there's going to be a decreased amount of insulin. There's decreased mailmen. So the mailmen normally deliver to 1 out of every 100 houses. Now they're going to be delivering to 1,000 houses. They're going to be overworked. So those are the three main principal problems that ends up occurring in diabetes. So what are the risk factors of developing diabetes? There are a lot of them. We'll talk about a few of them here, the most important being obesity. If you're obese, there's a very high chance that you'll develop diabetes in the future. If you're a female sex, for some reason, females are more likely to be diabetics than men. If you have other pre-existing conditions that might make you more susceptible of having diabetes, your heritage or genetics, for example, patients who are Hispanic or Indian Pakistani are more likely to become diabetic, or it's family history. If your family has it, your father, your grandfather, your mother, you're more likely to have diabetes. So what are some of the signs and symptoms? How do I, as a clinician, find out that you have diabetes? What are some of those key words? A lot of times, we find out that you're diabetic when you're asymptomatic. Basically, that means you have no symptom. Around 40% of the time, you don't have any symptoms of diabetes. We find out just randomly through, let's say you checked your sugar levels at your dad's house and you found out that your sugar level is high. So you go to your doctor. Around 40% of the times, you don't have any symptoms and we diagnose you with diabetes. A lot of the times, you'll have the classic symptoms, the polyuria, polydipsia, and nocturia. Why do you have these symptoms? So glucose, the molecule of glucose is very large and it floats around in your bloodstream when you have a lot of it. And when you pee it out, this glucose molecule that's very large drags with it a lot of fluid, a lot of water. When it drags a lot of water, you end up peeing a lot of water. You get dehydrated, so you start to drink a lot of water, so polydipsia. And since you're urinating a lot, that's polyuria. And this happens at the nighttime, especially after you have let's say a piece of cake. Your sugar levels are high after and you go to sleep, which is nocturia. In very rare cases, we find out you have diabetes in what's called DKA, or diabetic ketoacidosis. It's kind of like the keto diet where you have ketones in the body, but to the nth extreme. So let's say you're not having many symptoms or any symptoms. How would I as a clinician diagnose you? So one, you're going to have obesity, greater than the 85th percentile per your BMI. And you usually have one of the following. Either you have the classic symptoms, polyuria, polydipsia, nocturia, you have a family history of diabetes, or you have other pre-existing conditions that will increase your risk of having diabetes. So if you're females and you have PCOS, or you're large for gestational weight babies, or other diseases, that will make me think, or that will make me want to check to see if you have diabetes or not. So now I want to kind of go over the tests. What tests are there to diagnose diabetes and what are some of the cutoffs? The one is going to be a random blood sugar. That means I check your blood sugar randomly. If it's over 200, you have diabetes. The second would be a fasting blood sugar. That means you haven't eaten for 8 hours. Usually you fast overnight, and in the morning you check your sugar level. If it's over 126, you have diabetes. The third one is going to be with an OGTT, or an oral glucose tolerance test. That means I will give you a glucose load in the clinic, and 2 hours later I will check your sugar levels. If it's greater than 200, you have diabetes. I am sure a lot of you are familiar with the term hemoglobin A1C, but I kind of want to tell you what exactly it is. Basically, your RBCs, or your blood cells, once they are made, cannot take on any more glucose. Since they can't take on any more glucose, the glucose that they have inside we can measure, and that's known as the A1C, the percentage. So when you hear 7, 8, 9, that's 7%, 8%, 9% in that particular blood cell. The cutoffs that we're looking for here is greater than 6.5. If it's more than 6.5, you have diabetes, or 6.5%. If you have 5.7 or 6.4, that's where we term the phrase prediabetes. Now, if you are young, there are a couple of tests that we like to do, such as the anti-IA2 or the anti-GAD, but it's really not going to change our management. So what are our treatment goals? The first one is to get your hemoglobin A1C less than 7, and the second is to decrease our cardiac risk of having, let's say, a heart attack or stroke. We do that by making you stop eating really fatty foods, stop smoking, controlling blood pressure, to exercise and diet. I kind of alluded to this in the last sentence, but what are some of the complications? We break down complications via micro and macrovascular complications. So again, these are going to be heart attacks, strokes, kidney failure, neuropathy, which is basically numbness and tingling in your legs and your hands. What are our treatment options? So the first line treatment is always diet and exercise. We recommend exercising at least 150 minutes a week or 30 minutes a day, 5 days a week. Now there's a lot of medications that we can give for diabetes. Before you take any of these medications, I want you to talk to your family doctor before taking them. They all have side effect profiles, and I don't know you individually to prescribe them. What I want to go over now is mostly meant for boards. The first line medication I want to talk about is metformin. Metformin is the wonder drug of diabetes. It's so wonderful, in fact, that there's a lot of physicians, sometimes myself included, that want to take metformin and add it to the water supply. It is that effective. Now, these other medications are going to be the second and third line options, but in specific diseases, they are proven to help you out. So, for example, if you have coronary artery disease, then you should be on a GLP-1, such as a glutide, liraglutide. If you have heart failure, if you have chronic kidney disease, then you should be on an SGLT2 or empagliflozin, or one of the other SGLT2 inhibitors. Again, before starting any of these medications or recommending them to your physician, you should talk to your physician. Now, right around the time where your hemoglobin A1C gets greater than 9, that's when, as a clinician, I start to like adding insulin. Now, insulin is very different. There's a lot of different types of insulin, and I'm not going to go through them because I don't want to go through them. It's very complicated. In one of my next videos, I'll go over an inpatient insulin regimen for patients with diabetes, but I'm not going to cover that in this topic. All the other medications for diabetes are kind of falling out of favor. Flavor or favor? A lot of these other medications are falling out of favor. The reason being is that these newer medications, the GLPs, the SGLT2s, the DPP4s, are doing a much better job at controlling the hemoglobin A1C as well as the side effects of diabetes compared to the older medications. So that's a brief but in-depth overview at the basics of diabetes. I hope it all kind of makes sense. If you have any questions, please leave them in the comments below. I hope you all enjoyed. Have a good one.